Professor Sadiq is a global and coveted name in pediatric cardiology. Head Institute of Child Health and the Children's Hospital, Lahore. Professor Dr. Masood Sadiq has a very long list of accomplishments and honors and awards in recognition of his services in the development of pediatrics and pediatric cardiology in Pakistan. He has been awarded the prestigious Tamgha Imtiaz by the President of Pakistan on outstanding contribution in the field of medicine. He has also been awarded the SMK Wasti PPA Gold Medal Award by the President of Pakistan, the PPA Center Gold Medal, again by the President of Pakistan, the Wasti Memorial Gold Medal, and a Certificate of Appreciation by the Chief Minister of Punjab in recognition of his services as head of Children's Hospital. Apart from this, Dr. Masood has a wide array of publications, and we are absolutely delighted and honored to welcome him today. So without further ado, let us start today's awareness session, where the topic is physical activity in children with congenital heart diseases, the current guidelines. Professor Masood, please, welcome.
Thank you very much. I think let me start by thanking Pakistan Children's Heart Foundation and Mr. Farhan Ahmed for his outstanding effort and contribution to the cause of heart diseases in children. And I think we all being part of his this effort, we believe that inshallah one day we will succeed in our ultimate aim as well, which is to actually have treatment for all children with congenital heart disease in this country at their doorstep and free of cost, inshallah. Our today's topic is physical activity in children with congenital heart disease. I think this is a very important topic from a parent's perspective as well as from physician or pediatrician or cardiologist perspective, because this is something which is often either ignored or is not taken care of the way it should be taken. All children have a natural need to move, play, and perform physical activities. And I think this is necessary for their optimal physical, emotional, and psychosocial development. And generally, when we recommend sports or physical activity, we only focus on competitive sports. And we often tend to, excuse me, often tend to forget about leisure sports and exercise training programs where you can actually enhance their physical ability to perform certain physical activities. Most children with heart diseases at birth, or what we call congenital heart disease, are relatively sedentary. And I think partly the reason for that is that the parents and families tend to be overprotective. And they feel that if their child has a congenital heart disease or a heart defect, he or she should not be exercising at all. And that actually forms a vicious cycle because then they become obese, they become exercise intolerant, and then they would develop these psychosocial morbidities, which further enhance this vicious cycle. Therefore, I think it's duty of every physician that they encourage daily participation in appropriate physical activity whenever they encounter these children in clinic, outpatients, or inpatient. It's important to define what a physical activity means and what is a leisure sport, what is a competitive sport, because not many of us actually would have a very clear differentiation between these. Any activity or bodily movement that results in muscle contraction that increases the metabolic rate above the resting level would be a physical activity. Now, that can be a leisure sport, that can be a recreational physical activity, it can be static, it can be mobile, it can be a competitive sport. And we generally define vigorous activity as when we increase our metabolic rate by more than 6 metabolic equivalent. I think it's important to define MET, or because it is considered as the amount of oxygen consumed while sitting at rest. Moderate activity is defined as activity which is within 3 to 6 MET. Now, leisure sport is something which we often forget. It's a recreational physical activity without any pressure on the child to play, continue to play, or play at a higher intensity than is desired by the participant. It's like you are listening a telephone call and you start walking while you are listening to the phone or talking to somebody. And by the time you finish your phone, you have already spent 10 minutes of walking. And you didn't realize that you have walked 10 minutes. So that's a sort of a layered sport or recreational physical activity where you actually don't realize, and there's no pressure on you to continue or have a higher intensity. When it comes to competitive sports, they are organized, competitive, skillful physical activities, which are obviously inside fixed rules of commitments and fair play. And of course, it involves pressure because you are competing with somebody. So pressure to train or play or continue to train or play at a higher intensity. These are cricket match, football match, rugby match, or any other competitive sport where you are actually having a higher physical activity. Exercise training is a specialized planned method and programs of physical activity where you actually increase an individual's physical activity capacity, performance, and fitness. And that's something I think which we need to concentrate on these children with congenital heart disease, because they often become sedentary and they are not in a habit of doing physical activity. Hence, their exercise capacity decreases. Sedentary lifestyle is defined as a lifestyle with no or marginal regular physical activity or exercise. And I think with this mobile phone and computer, we are seeing more and more children getting used to this sort of lifestyle, and hence they become obese. They are having psychosocial problems. Believe you me, I see every other day a adolescent in my clinic or otherwise, parents asking for an opinion where their children are addicted to these mobile phones. They don't sleep properly. They don't do any physical activity. And just imagine a child who has a congenital heart disease and gets into this habit, what would be the outcome? The current physical activity guidelines for children are that they should be playing daily for at least 60 minutes. And that physical activity does not mean competitive sports. It can be leisure sport, recreational sport, or other training period. But out of these 6 days, at least 3 days have to be vigorous physical activity. And we defined vigorous physical activity. So muscle and bone strengthening activities are recommended for at least 3 days a week. And in contrast to more familiar aerobic, I think high impact and anaerobic burst exercises such as jumping, which used to be a historical thing for children to do, is going to be very conducive to achieving this particular goal. Before we actually recommend anything to these children, it's extremely important that the physician or the cardiologist or pediatrician actually does a fair assessment, a thorough assessment of patient's current level, his tolerance or her tolerance to exercise. And it's also important to speak to these children and find out what they think about physical activity and fitness, because their approach to life is important. If the child thinks that he needs to be sitting with a mobile phone all day, you need to change that mindset and have to convince that child that the physical activity is important. So obviously this assessment of level. What is extremely important is to elicit presence of any exertional symptoms. And this is crucial for congenital heart disease. Chest pain, excessive shortness of breath, palpitation where you feel your heart feeling or thumping, dizziness where you feel that you're about to drop off or go unconscious, and of course genuine syncope. So if you in history find out that child is having any of these symptoms, obviously your assessment would be totally different. Even in the absence of such symptoms, I think you still need to have an objective assessment of a child before you allow that child with a certain congenital heart disease to have a certain physical activity. And formal exercise testing is sometimes recommended because if you cannot get a proper history, if there is no evidence of the presence of exertional symptoms, but the clinical condition demands that you need to define it more scientifically and more appropriately, you should go put them through ETT. This is a slightly busy exercise, just giving you a classification of what different sports are. I think anybody can go on net these days and find out. When we say what is a low intensity sport and what is a high intensity sport, there are two things which we look at. One, we see what is the static component in that, and how we increase that component. And second is obviously the maximum oxygen consumption. So voluntary contraction and oxygen consumption are the two things. So you can see playing badminton or cross country or skiing will fall into both a dynamic as well as static component as a high intensity sport. On the contrary, if you are playing golf, that's taken as a low intensity, low static component sport. And then there will be a range, because this is an American sort of paper. You can see majority of the sports mentioned here are obviously what is being played in America. But of course, if we are playing games according to our local setup, you can easily put those into this equation. So how do we evaluate? I think there are certain steps of evaluation by a physician. One, of course, you need to look at the history and physical examination. So you take history, as I elucidated earlier, and go through physical examination to find out what exact clinical status the child is in. You need to assess 5 baseline parameters, and I will be coming to these 5 baseline parameters in a moment. And once you have assessed those 5 baseline parameters, then you recommend what type of exercise that child with that particular clinical condition can undergo. And then, of course, if needed, you will, as part of assessment, you will put them through cardiopulmonary exercise testing. Now, this is an extremely important slide, because this gives you those 5 parameters which we look at when we are looking at congenital heart disease. One, very important, ventricles. And when we say ventricles, there are 2-3 important things in ventricles that we look at. Function, most importantly, ventricular function. And remember, it's not only the right ventricular or left ventricular function, you're looking at both systolic and diastolic function as well. So both ventricles, systolic and diastolic function, any evidence of hypertrophy or pressure or volume overload needs to be determined. And then we classify them into 5 parameters. No dysfunction will be A, no systolic dysfunction, but evidence of pressure or volume overload will be B, mild hypertrophy and mild systolic dysfunction would be C. If you see moderate systolic dysfunction, of course, that will be D. And if you see severe dysfunction, this will fall into E. So these are the 5 fundamental parameters that I mentioned. The second and extremely important parameter is actually pulmonary artery hypertension, whether the pressure is low, mildly elevated, moderately elevated, or severely elevated. As you can see, even moderate elevation of pulmonary artery pressure is E, is parameter 5. Aorta, you need to see aortic dilatation, because that puts you at an extra risk of potential complications during exercise. So mild dilatation, moderate, severe dilatation approaching indication for repair. Arrhythmias. I think arrhythmia is something which you may not be easily able to pick up on an exercise, on history. So these are the patients where if you seriously suspect there may be a possibility of an arrhythmia, you need to exercise them. And of course, you also need to put them through a formal ETT or Holter monitoring. Saturations, particularly important in cyanotic children. And particularly important that how much do they drop their oxygen while exercising. So in some of them, you would need to put them through exercise testing. So these 5 parameters actually determine how much physical activity you are going to allow to a child with congenital heart disease. So remember, ventricles, pulmonary artery pressure, aorta, arrhythmias, saturation. Now, then you need to put them together and see which component of sport, whether it's a static component or a relative intensity of the sport, and how do you, in different 5 these groups, how you are going to allow them a high intensity sport, a moderate intensity sport, or a low intensity sport. Of course, if they fall in category A or B, you will be allowing most of these children a high intensity sport. But if they are in a category E, of course, you cannot let them them even in a moderate intensity sport. They can only be trained to do some low intensity sports. Exercise testing, although there in literature, many people recommend that, you have to be a little careful when you actually do these patients or these patients undergo exercise testing. But it's extremely important actually, because unless you do that, you will not have a scientific evidence to say whether the child has any symptoms during exercise or not, and particularly the risk of arrhythmia or syncope. Aerobic exercise performance, again, this is assessed by determining the maximum oxygen intake, not always met in children and not easy in children as well. Now look at this chart, and I think this diagram gives you more information than any written information that you can get. Basically, these are exercise testing parameters for various congenital heart defects, and you can see how they are reduced during exercise. Now, on your left is your peak oxygen uptake, and on your right is peak heart rate. And you can see, look at children with aortic stenosis, Fontan circulation, and tetralogy, the three risk groups, and see how their oxygen falls. Oxygen uptake is low. Similarly for Fontan circulation and children with tetralogy, and see how their heart rate can go up significantly, potentially risking their physical activity if they go for a high risk intensity. So it's important to remember what their heart rate, maximum heart rate can be allowed, and what sort of fall in oxygen uptake or can be expected. Once you have done their cardiopulmonary exercise testing, only then you will be recommending what relative intensity physical activity can they be doing. And you need to remember this cycle all the time. History, physical examination, assessment of 5 baseline parameters, type of exercise recommendation, if necessary, perform cardiopulmonary exercise testing, and then recommend relative intensity of that. And it's important to follow them, because that follow-up might change your plan. And you might be coming back to your history and physical examination and then reassessing these children through this algorithm once more. Lastly, let's come to what clinical recommendations would be overall, as well as to specific cardiac lesions that we are going to recommend. I think 3 important, I gave you 5 parameters, but 3 of them are absolutely crucial. So as long as there is no exercise-induced arrhythmias, resting myocardial dysfunction, or pulmonary hypertension, you can recommend normal physical activity in most of these children. So no limitations exist for competitive sports if they don't have any of these. And the only major limitation is pulmonary arterial hypertension. Any degree of pulmonary hypertension puts you at an added risk during physical activity. Let's take these lesions one by one. Common ones. Of course, we can't go through the entire list of congenital heart disease, but the ones which constitute more than 80% of congenital heart defects, I will just quickly go through them. Atrial septal defect, no limitation on physical activity. It holds true for both leisure or other physical activities. Remember, if you had an interventional or device closure, then of course, immediately after device closure, you should not be putting these children through any sort of activity, particularly for the first 14 days. But I think contact sports should be avoided for 6 months. It takes for the device to endothelialize in 6 months. So to avoid the risk of dislodgement, competitive contact sports should be prohibited for 6 months. If it's a surgical closure, then of course, after the healing of sternotomy wound, there are no restrictions whatsoever. Ventricular septal defect, I think it depends upon the size. If it's a small or moderate defect, they can perform physical activity and participate in all sports at all levels. If it's a large defect with pulmonary hypertension, then the same restrictions would apply as apply for pulmonary hypertension otherwise. So any child who has large VSD with severe pulmonary hypertension must be restricted from competitive and contact sports because they will be contraindicated considering the severity of pulmonary hypertension. If you had a repaired or unrepaired ventricular septal defect, but it's a small or moderate size, absolutely no restrictions. I think if exercise capacity is abnormal, then you need to put them into a training program because the parents might have been restricting them for nothing, thinking that their child has a hole in the heart. And you restrict them because you think it's something which they should not be doing. And then they are physically unfit. Please make them fit. Put them through a training program because there's absolutely no restriction for a child with small to moderate VSD. If you have done an interventional or surgical VSD closure, the recommendation is same. 6 months for device closure because it takes that long to endothelialize, and till the sternotomy wound is healed for surgical closure, which is again actually 3 to 6 months, almost the same period. PDA, same. If it's small to moderate, no restriction. If it's a device closure, same, let it endothelialize. So restrict them for 3 to 6 months. Same for surgical, because it's normally a little thoracotomy scar, it heals much quickly. So after 3 months, you can let them do whatever they want to do. But one condition where there is a restriction is PDA with pulmonary hypertension. So any degree of significant pulmonary hypertension, they need to be restricted. Obstructive lesions. I think the most important obstructive lesion to remember is aortic stenosis because they can drop dead. If you don't restrict them, and if they have a significant aortic stenosis, and if they didn't know about it, and if they get involved in a very high intensity competitive sport, they can actually unfortunately drop dead. So it's extremely important that they engage in low intensity leisure sport and physical activity depending upon symptoms and findings at exercise testing. I think most of these show reduced aerobic exercise performance. And if you see any degree of ECG changes on exercise testing, a drop in blood pressure, an inadequate rise in blood pressure with increasing intensity exercise, or any arrhythmia, contact sports, high intensity sports are contraindicated. Because these are the children who can potentially suddenly, because they have a fixed cardiac output, they can actually immediately drop their blood pressure and can drop dead. Sudden cardiac death during exercise has been reported, and I think it's either related to malignant arrhythmias which occur in these patients or a sudden drop in their cardiac output. So patients who report syncope, dizziness, angina, or disproportionate dyspnea must be sent for either surgery or intervention, because that will be an indication to do something about these children. But if they have a mild to moderate aortic stenosis, I think they can be allowed moderate exercise, including recreational sports. Pulmonary stenosis, I think almost similar will apply to pulmonary stenosis as to the aortic stenosis. The only difference is obviously because the pulmonary stenosis relates to right side, so your RV pressure tends to be considerably high, and these children should also avoid high intensity sports if they have severe PS. But I think if it is severe PS, it's an absolute indication for intervention. They should be treated. So the cardiologists need to go ahead and do a valvuloplasty. And once the valvuloplasty is done, then the only consideration is how much pulmonary regurgitation they have. If they don't have any PR or mild PR, normal physical activity. If they have severe pulmonary regurgitation, of course, then their exercise performance will be limited. Coarctation of aorta. I think coarctation of aorta again should be treated and dealt with in the same way as aortic stenosis. So it's as dangerous as aortic stenosis, rather more dangerous because you develop upper limb or upper body hypertension with it. So there is also a risk of cerebral rupture of cerebral aneurysm or heart failure associated with severe hypertension, systemic hypertension. So if it's an unoperated, same recommendations as aortic stenosis, depending upon the severity of coarctation and presence of hypertension. If you have done already surgery or intervention and there is no gradient across without any evidence of aortic or cerebral aneurysm, I think they can take part in physical activities. Of course, it's important to remember what restriction would be there, but an active lifestyle, and I think even aerobic training should be promoted in these patients as primary prevention against typical long-term sequelae in these children with coarctation of aorta. Last component is cyanotic heart disease. I think in cyanotic heart disease, I will be touching only a couple of lesions because otherwise we can go on. In patients with tetralogy, if you have an asymptomatic, untreated tetralogy, of course, if they exercise, you run them a risk of cyanotic spell. So any child with tetralogy of Fallot above 1 year of age, consider for surgery or surgical repair. Once they had surgical repair, then they are generally asymptomatic, and you can allow them adequate physical activity without restricting them. The only problem is if they have a significant residual lesion. And when we say residual lesion, either residual PR, residual VSD, or significant pulmonary regurgitation, because then in later life, they run risk of ventricular arrhythmias. And it's important for these patients that every child post-tetralogy needs individual assessment. You can't generalize. You can generalize for ASD, you can generalize for VSD, PDA, but you can't generalize for tetralogy of Fallot because the outcome is so variable. It can be significant PR, you may have a small residual VSD, you might have a branch pulmonary artery stenosis, you may have RV dysfunction, you may have secondary LV dysfunction. So I think it's important to remember all these residual lesions and give an individual approach to every patient. Transposition, I think if the child had an arterial switch operation, which was successful with no LVOT or RVOT obstruction, they should be allowed normal sports. But I think if they had an atrial switch operation, which is either mustard or Sanning, you need to individually, they must be exercised. You can't let a child with mustard or Sanning operation undergo normal physical activity unless you have excluded arrhythmias. And you will be surprised how many of them would have some degree of arrhythmia either on Holter or exercise testing. So every patient with post-atrial switch needs to be individualized and have a careful assessment before advising high-intensity sports. Fontan circulation or post-Fontan, where you go for a univentricular heart, I think the circulatory output after Fontan we know is regulated by pulmonary vasculature, and which limits ventricular preload. So because there is absence of subpulmonary pump, it limits their normal increase in pulmonary pressure, transpulmonary flow requirements, and cardiac output. And heart rate response we know is usually blunted because there is no appropriate ventricular preload for these children. And a very fast heart rate in these patients can, with a limited preload, can result in a severe decrease in stroke volume, leading to hypotension, syncope, and these children can also die suddenly. So I think with that background of Fontan circulation, again, these children need to be evaluated, assessed, all these parameters fulfilled, which we talked about earlier. If necessary, have a Holter, have an exercise test, and only then you can allow them. Another important parameter in these patients is oxygen saturations, both at rest as well as during physical activity. Most have a limited exercise tolerance, and I think these children should be encouraged to perform mild physical exercise and to perform low intensity sports, avoiding high intensity activities, particularly if they have any degree of desaturation, ventricular dysfunction, desaturation during exercise, or evidence of an arrhythmia. Ventricular dysfunction, I think you need to know the etiology and degree of dysfunction because that determines your recommendations. In these patients, you have a risk of arrhythmia and sudden death. So patients with significant ventricular dysfunction should be counseled to enjoy a wide range of recreational sport and avoid competitive or contact sports. And I think it's important to limit their involvement in contact or competitive sports. When it comes to adults, one important group is Eisenmenger syndrome. These are children who either had an ASD, VSD, PD, or an atrioventricular septal defect and has developed Eisenmenger. In one of the landmark study by Delineto and his colleagues, they looked at 61 deaths with Eisenmenger syndrome. And they were none of them was related to sports or exercise participation. So I think generally leisure sports and physical activity should be allowed, as long as there is no deterioration in their saturations and there are no symptoms that we have mentioned earlier on. Patients with pulmonary hypertension without shunt must avoid physical activity, because one of the fundamental things in idiopathic pulmonary hypertension is syncope and sudden death. Similarly, all patients should be individualized. Pulmonary hypertension is again something where it may be mild, moderate, or severe. It may be primary or secondary. It may be with RV dysfunction and without RV dysfunction. It may be with desaturation and without desaturation. So I think remembering those 5 parameters which we mentioned earlier on, every child needs to be individualized, and then the recommendations should be based on what you find in these different parameters. So in summary, I think if you have mild AS, ASD, VSD, AVSD with no pulmonary hypertension, pulmonary stenosis with no gradient, and you have a tetralogy, repaired tetralogy with no residual lesion, you don't need to restrict them. If you have a coarctation of aorta, you must avoid high intensity static sports. Remember, static sports. And this is a specific group, coarctation of aorta, where we categorically ask them to avoid high intensity static sports. Gym is a typical example. And then there are conditions where you avoid high intensity static as well as dynamic sports is significant aortic stenosis, post-Fontan, significant pulmonary stenosis, transposition where there is an aortic stenosis, repaired or unrepaired pulmonary arterial hypertension, hypertrophic cardiomyopathy, and any child which has shown evidence of exercise-induced arrhythmia. What you can do or allow in terms of cardiorespiratory, musculoskeletal, or other, I think healthy children, the recommendations are very clear. Septal defects, healthy children. Aortic stenosis depends upon mild, moderate presence or absence of aortic regurgitation. Coarctation of aorta or aortic dilatation or aneurysm, you can see, again, these are classical guidelines, which I think every physician should have a table on his desk, or these days maybe in his mobile phone, to see when they are recommending for these important conditions, because each one of them would have a clear recommendation, whether it's pulmonary stenosis, tetralogy of Fallot, pulmonary regurgitation, Epstein's anomaly, transposition after atrial or arterial switch, transposition where it is a congenitally corrected, single ventricle or Fontan, those who have implanted devices like pacemaker or defibrillator, and patients with Eisenmenger syndrome. I think these recommendations are very clear cut in terms of cardiorespiratory, musculoskeletal, and other physical exercises which you can do. I would like to conclude by saying that counseling of patients with congenital heart disease should always emphasize the importance of daily physical activity and decreasing sedentary behavior as per clinical status of the patient. Please discourage mobile phones. Please tell the parents that 1 hour physical activity every day is a compulsion, and 3 days strenuous physical activity in a week, 1 hour daily, is a compulsion. There's absolutely no evidence regarding whether or not you should be restricting recreational physical activity. Please don't restrict recreations in these patients, because even unless they have rhythm disorder, and I think those are specific patients where you will be restricting them up to a certain level. And I think healthcare professionals must tailor their recommendations to each patient's clinical status. And I think this is extremely important. Every patient has to be individualized, looked at all these parameters, determine what it is, if necessary, do physical exercise testing or Holter monitoring, in addition to getting a detailed history and physical examination and doing an appropriate ECG and echocardiogram. And then the focus should be on the health benefits of physical activity and promoting appropriate participation for all sports. They must comply with public health recommendations. Physical activity counseling should be a priority. And I think clinicians must provide, if possible, written recommendations to both primary care providers, and I think it's important. When you see these children, they go to a pediatrician, they go to a GP, and the GP would stop them from doing anything. And I think it's important that we educate our primary care physicians, both general practitioners and general pediatricians, as what is an appropriate level of physical activity and exercise for various congenital heart defects. And I think most of the provided recommendations are based on expert opinion, except in very few studies. So I think further research is also important, and each one of us can participate in this research to see what should be the ideal recommendations in these patients with congenital heart disease. I think I would like to stop here. And if there are any questions, I will be happy from any of the participants. I will be happy to take those questions. And of course, I will be happy to answer questions otherwise if there are any. Thank you very much.
Thank you very much, Dr. Masood. That was a complete and a very informative lecture, and definitely it has highlighted a very important and unfortunately ignored aspect in the management of congenital heart disease in Pakistan. And I completely agree on the importance of integrating physical activity in the management of congenital heart diseases. So if there are any questions from the panel, we will move on to the question and answer session.
Farhan has put in two questions here. One is that we should be doing it in Urdu. I didn't see that. If I would have seen it, I would have done the entire talk in Urdu. But I think we can do it again. We can repeat it if there is a desire. We can, on another day, we can obviously do it in Urdu for our parents. I thought this was primarily focused on primary care physicians, pediatricians and pediatric cardiologists. That's why I actually focused or did it in English. Farhan has also raised a question that most mothers think that they should be restricting their physical activity because their child has a congenital heart disease. And I think that's the whole message of this presentation. हमें बहुत क्लियरली माओं को बताना है कि आपके बच्चे को अगर दिल की बीमारी है तो इसका हरगिज ये मतलब नहीं है कि वो फिजिकल एक्टिविटी में हिस्सा नहीं ले सकता, बल्कि मेजॉरिटी बच्चे, तो आप अगर उन 4-5 कंडीशंस को देखें जिनका मैंने जिक्र किया है, जहां पे आपके बच्चे को शदीद किस्म का वाल्व तंग है या शरेआन तंग है या बच्चा ब्लू है, अदरवाइज तो कोई रिस्ट्रिक्शन है ही नहीं है। बल्कि अक्सर ये बच्चे रिस्ट्रिक्शन की वजह से सेडेंटरी लाइफस्टाइल के आदी हो जाते हैं, उनका मोटापा आ जाता है, दे बिकम ओबीस, और फिर उसके साथ बेशुमार साइको सोशल प्रॉब्लम्स आना शुरू हो जाती हैं। तो आई थिंक इसलिए बहुत इंपॉर्टेंट है कि हम पेरेंट्स को ये कैटेगोरिकली बताएं कि उनका बच्चा किस लेवल की फिजिकल एक्टिविटी में हिस्सा ले सकता है।
Thank you, sir. There is one question from one of our audience members. It is a mother of a CHD girl, and she has asked that my child has had a BT shunt 3 months ago, and her age is 16 months now, but she hasn't achieved any milestone except neck holding and sitting. Is it normal in a CHD child?
थैंक यू। ये नॉर्मल तो नहीं है किसी CHD के बच्चे में, लेकिन इसमें दो चीज़ें इंपॉर्टेंट है। एक तो ये है कि हमें ये जानना होगा कि शंट से पहले बच्चे की कंडीशन क्या थी, और क्या ये नेक होल्डिंग और सिटिंग शंट के बाद आई है या पहले से मौजूद थी। और सेकंड, जो बच्चे ये साइनोटिक हार्ट डिजीज के होते हैं जिनकी ऑक्सीजन कम होती है, तभी आप BT शंट करते हैं, तो इन बच्चों के माइलस्टोन्स नॉर्मल बच्चों से वाकई थोड़े पीछे होते हैं। तो आई थिंक इट्स इंपॉर्टेंट कि एक तो ये पता चले कि जब से शंट हुआ है तो क्या उसमें बेहतरी आई है या नहीं आई, और अगर बेहतरी आई है तो आई थिंक इंशाल्लाह हमें एक्सपेक्ट करना चाहिए कि ये वक्त के साथ साथ ये बाकी माइलस्टोन्स भी अचीव कर ले।
Thank you, sir. So, मेरी तरफ से एक question था. You highlighted the importance of physical activity in children with congenital heart disease. So, can you please elaborate what impact it has on the prognosis and life expectancy of a child?
आई थिंक जहाँ तक प्रोग्नोसिस का ताल्लुक है तो और लाइफ एक्सपेक्टेंसी दोनों इम्प्रूव होती हैं अगर आप बच्चे को फिजिकली एक्टिव कर देते हैं। तो आई थिंक जैसे एक नॉर्मल इंसान में होता है, उसी तरह चाइल्ड विद कंजेनिटल हार्ट डिजीज में आपकी लाइफ एक्सपेक्टेंसी भी बढ़ जाती है और आपकी क्वालिटी ऑफ लाइफ भी इम्प्रूव हो जाती है। और आप जब फिजिकली फिट होते हैं तो आप मेंटली फिट भी होते हैं। तो इसका कोरिलेशन है आपस में। तो आई थिंक ये बहुत इंपॉर्टेंट है पेरेंट्स के लिए जानना कि अगर उनके बच्चे फिजिकली एक्टिव होंगे तो एक्चुअली आप उनकी लाइफ एक्सपेक्टेंसी को बढ़ा देते हैं और उनकी क्वालिटी ऑफ लाइफ को भी बढ़ा देते हैं। एक और सवाल मैं देख रहा हूँ जो एक मदर की तरफ से, जिन्होंने लिखा है कि उनका 5 साल का बच्चा है जिसको डाउन सिंड्रोम है और अब वो क्लिनिकली ऑपरेबल है, लेकिन उसकी सैचुरेशन 87 और 99 के दरमियान है और वो अदरवाइज एक्टिव है। तो क्या फिजिकल एक्टिविटीज वो कौन सी कर सकती हैं? पहली बात ये है, इंपॉर्टेंट ये है कि आपने उसको रिस्ट्रिक्ट नहीं करना। ये बच्चे डाउन सिंड्रोम वाले ऑब्वियसली इनकी फिजिकल एक्टिविटी उस लेवल की नहीं होती जैसे नॉर्मल बच्चों की होती है। तो जो डे टू डे घर पे बच्चे खेलते हैं आपस में, उसमें आपको उसको रिस्ट्रिक्ट करने की जरूरत नहीं है। ऑब्वियसली चूंकि ये बच्ची को पल्मी हाइपरटेंशन है, तो और ये सवेयर पल्मी हाइपरटेंशन है, तो इन बच्चों को हम किसी कम्पेटिटिव या कॉन्टैक्ट स्पोर्ट में हिस्सा लेने की इजाजत नहीं दे सकते। लेकिन वो तो फिर होगा भी नहीं ना, क्योंकि डाउन सिंड्रोम के बच्चे नॉर्मली कम्पेटिटिव स्पोर्ट्स में या कॉन्टैक्ट स्पोर्ट्स में हिस्सा नहीं लेते। लेकिन जो घर पे बाकी बहन भाइयों के साथ खेलना है, थोड़ा बहुत घर में आगे पीछे भागना दौड़ना है, आई थिंक यू शुड नॉट स्टॉप देम, शी विल बी अलाउड टू डू दैट।
Thank you, sir. There's one more question from my side. You elaborated the importance of physical activity and the clinical correlation. Sir, इसके अलावा जो है, is there a correlation with the gender of a child, age, weight, and other comorbidities?
ऑफ कोर्स, चूंकि हमारा फोकस जो था वो कंजेंटल हार्ट डिजीज था, तो मैंने उन पैरामीटर्स को हाईलाइट किया जो कि कंजेंटल हार्ट डिजीज से रिलेट करते हैं। लेकिन ओवरऑल जब हम बच्चे को असेस करेंगे तो ऑब्वियसली उसकी एज, उसका वेट, उसकी हाइट, उसकी जो सोशल स्टेटस, ये तमाम चीज़ें इंपॉर्टेंट होंगी। और अभी एक मैं क्वेश्चन देख रहा हूँ हमारे एक पेशेंट की तरफ से जो कि अब एडल्ट हैं, और उन्होंने लिखा है कि आई एम एन एडल्ट टी ऑफ पेशेंट और माशाल्लाह इज डूइंग वेरी वेल। तो उन्होंने मेंटल हेल्थ एस्पेक्ट को हाईलाइट किया है कि जो बड़ों में एडल्ट्स जिनको कि कंजेंटल हार्ट डिजीज होती है, जब वो बड़े हो जाते हैं तो उनमें जो मेंटल हेल्थ प्रॉब्लम्स आते हैं उनके बारे में क्या ख्याल है। आई थिंक बेटा आपने बहुत ही इम्पोर्टेंट पॉइंट रेज किया है। अनफॉर्चुनेटली अभी तक पाकिस्तान में चूंकि बच्चों के दिल के माहिर डॉक्टर ही बड़े थोड़े थे, तो जो दिल के बीमारी के साथ बड़े हो रहे हैं उनके माहिर डॉक्टरों की तादाद तो है ही नहीं। बल्कि इस वक्त पूरे मुल्क में कोई एक भी डॉक्टर नहीं है जो कि ये कहे कि मैं सिर्फ उन बड़ों को देखता हूं जिनको पैदाइशी दिल का नुक्स है। अगर चाहिए स्पेशलिटी इंग्लैंड में, अमेरिका में, डेवलप्ड कंट्रीज में अब फुली डेवलप हो चुकी है, और बेशुमार बड़ों के कार्डियोलॉजिस्ट और बच्चों के कार्डियोलॉजिस्ट जो हैं वो इस फील्ड में जा चुके हैं, जहां पे वो सिर्फ उन बच्चों को देख रहे हैं जिनको पैदाइशी दिल का नुक्स था, उनका ऑपरेशन हुआ या ना हुआ, जब वो बड़े हो गए तो उनकी जो मसाइल है उनको देखते हैं। हमारे यहाँ अभी हम लोग ही, यानी मुझे आप कह लें जो मैं बच्चों के दिल का डॉक्टर हूँ, या मेरे बाकी तमाम दोस्त जो कराची, पिंडी, पेशावर, फैसलाबाद, मुल्तान या बाकी जगहों पे बैठे हुए हैं, वो तमाम लोग बच्चों के दिल के डॉक्टर ही बड़ों को देख रहे हैं। तो ये बहुत ही इंपॉर्टेंट एस्पेक्ट है और इसमें योर पॉइंट इज वेरी वेल टेकन। आई थिंक हमें एक और टॉक इसके ऊपर करने की जरूरत है कि वो बच्चे जिनको जो एडल्ट्स हो गए हैं उनके जो मेंटल हेल्थ प्रॉब्लम्स हैं उनको हम कैसे डील कर सकते हैं।
सर नेक्स्ट क्वेश्चन एक आया है डॉक्टर अब्दुल मुगल से। वो पूछ
जी
रहे हैं,
रजाक की तरफ से 6 मिनट वॉट टेस्ट के, आई थिंक रजाक ये वेरी वैलिड पॉइंट है। मोस्ट ऑफ द टाइम्स हम 6 मिनट वॉक टेस्ट ही रिकमेंड करते हैं, क्योंकि जो प्रॉपर ईटीटी जो होती है वो उसके लिए एक सर्टन एज लिमिट होती है और फिर आपको उसके लिए सर्टन प्रिकॉशंस और प्रेपरेशंस की भी जरूरत होती है। तो यस, मेजॉरिटी बच्चों में 6 मिनट वॉक टेस्ट ही हम रिकमेंड करते हैं। आप ये कह लें कि अप टू द एज ऑफ 12 ईयर्स आप यू विल ऑलवेज गो फॉर ए 6 मिनट वॉक टेस्ट फर्स्ट। अगर और कुछ बच्चों में जो कि ऑब्वियसली जो 12 साल से बड़े हैं उनमें आप प्रॉपर ईटीटी भी कर सकते हैं।
जी सर, थैंक यू। Following up on the mental health aspect, I think is conversation is talked with our expert Dr. Masood Sadiq का मकसद ही ये था कि just because your child has congenital heart disease या कोई से दिल का अमराज है, does not mean कि they should lead a sedentary lifestyle. बस उसके असेसमेंट जो है वो अप्रोप्रिएट होनी चाहिए, काउंसलिंग होनी चाहिए, और उसके हिसाब से योर चाइल्ड कैन लीड। ऑफ कोर्स बच्चों को तो उनको शौक भी है, खुशी से फिजिकल एक्टिविटी में पार्टिसिपेट भी करते हैं, एंड दे कैन बी एबल टू डू इट. You just have to be a bit more cautious and follow these guidelines for children with congenital heart disease.
प्रोफेसर
Sir,
एहसन बेग ने बहावलपुर से सवाल पूछा है, प्रोफेसर एहसन बेग प्रोफेसर ऑफ पीडियाट्रिक कार्डियोलॉजी हैं बहावलपुर में, कि कैन वी गो फॉर डोपामीन स्ट्रेस टेस्ट और यस डोपामीन स्ट्रेस एको। तो एहसन जवाब ये है कि नॉर्मली तो आपको इसकी ज़रूरत नहीं पड़ेगी। बहुत ही स्पेसिफिक इंडिकेशंस हैं जहाँ पे आप डोपामीन स्ट्रेस टेस्ट कर सकते हैं, वेयर यू वांट टू सी कि अगर आप हार्ट रेट बढ़ाएंगे तो क्या होगा, क्योंकि दैट इज़ द होल आइडिया कि बजाय इसके कि आप ईटीटी करें, आप ये कह रहे हैं कि अगर हम उनका डोपामीन स्ट्रेस एको या डोपामीन स्ट्रेस टेस्ट करके देख लें, यस इन ए वेरी वेरी सेलेक्टिव पेशेंट्स यू कैन डू इट, अदरवाइज मेजॉरिटी बच्चों में तो आई थिंक इसकी इंडिकेशन नहीं है। अभी सेम हमारे जो दोस्त हैं उनकी तरफ से मैसेज है कि अगर ये मेंटल हेल्थ के ऊपर अगर कोई टॉक होती है तो he will be very keen to join that. I think we can work around that. I will speak to my colleagues in UK and USA. I know a couple of them actually are doing adult congenital heart disease as a specialty now. जैसे डॉक्टर दाऊद हैं, I know UAE में हमारे colleague दोस्त हैं जो कि adult congenital heart disease के patients को देखते हैं, primarily देखते हैं, हम सब देखते हैं लेकिन वो primarily देखते हैं, और चूंकि उनका background भी पाकिस्तान से है, तो I think I would either request him or any my colleague in UK or USA to give a talk on mental health in adults with congenital heart disease.
thank you,
So
sir.
thank you very much once again.
Thank you very much, sir. We are absolutely honored for this awareness session, and of course to have you as our honorary board member for Pakistan Children's Heart Foundation. It is an absolute privilege for such an honorable and coveted name to be part of our cause. And we will have some concluding comments from Mr. Farhan Ahmed, please. And then inshallah we will conclude the session.
जी अस्सलाम वालेकुम।
जी वालेकुम अस्सलाम फरहान।
Professor Jazakallah Khair, I on behalf of Pakistan Children's Heart Foundation always admire your commitment to the CHD cause and thank you very much sir। आज बहुत ही एक ऐसा टॉपिक जिस पर बहुत सारे पेरेंट्स बात करना चाहते हैं, सुनना चाहते हैं, बिकॉज हमारी वन ऑफ द चैलेंज जो हम फेस करते हैं वो ये है कि हम बात करने से घबराते हैं एज ए पेरेंट, लेकिन अल्हम्दुलिल्लाह वो सारी बातें आपने आज तफसीली की एंड वी आर वेरी वेरी थैंकफुल कि ये सिलसिला भी शुरू हुआ है सर। और जैसे आपने बताया कि सर एडल्ट कंजेनिटल हार्ट पर हमारे जो PCHF NA में डॉक्टर अली जैदी हैं, ही इज आल्सो वन ऑफ द हमारा स्केड्यूल हुआ है, तो इंशाल्लाह आई थिंक मिड फेब के अंदर सर उनकी टॉक होगी ऑन दिस। और ये सीरीज ऑफ डिस्कशन है सर, सीरीज ऑफ टॉपिक्स हैं जिस पर वी आर वेरी ऑनर्ड कि आप लोग टाइम देते हैं और इस कॉज पर आप लोगों की डायरेक्ट कंट्रीब्यूशंस हैं, तो आई एम वेरी वेरी थैंकफुल सर। आप सब लोगों का बहुत बहुत शुक्रिया। थैंक यू सर।
थैंक यू डॉक्टर, थैंक यू फरहान साहब, बहुत शुक्रिया। अब हम आपको डॉक्टर कहना शुरू हो गए हैं लेकिन कोई बात नहीं।
जी जज़ाकल्लाह खैर।
Thank you very much, Dr. Masood, आपके टाइम के लिए, आपके एक्सपर्टीज के लिए, और हमेशा for being such an honorable part of the CHD cause in Pakistan. And thank you to all our panelists for joining, parents, anyone who listened to us and was with us during the talk today. Thank you, everyone, and Allah Hafiz.